You are listening to Lifeboat for the White Coat podcast.
Welcome to the Lifeboat for the White Coat podcast number 4. Today we are having a conversation with Dr. Demetrio Aguila, and we thank you so much for taking your time and spending it with us today. I am so excited to speak with you and to truly hear your story of how you got to be where you are, and especially the programs that you are currently running that give people who typically don't have a chance. So welcome, Demetrio, to the Lifeboat for the White Coat podcast.
Well, thank you for inviting me. I was really flattered and actually a little bit surprised. I was like, I'm just a surgeon, just trying to make my way in the world and take care of my family. And here we are having this conversation. So.
Well, you are an absolute inspiration based on what I have seen and what you offer. I'm super excited to hear your story in depth and really find out, what made you make the decision to do what you're doing and not allow the typical healthcare system, keep their thumb pushing you down. So, Matt, I'll let you take things over at this point and really ask Dr. Aguila the questions that are going to be really exciting for people to hear.
Yeah, sounds great. So, Demetrio, thank you for taking the time to be with us. I know you're a busy man. And we all are, and we're doing unique things in this movement. I've had the privilege of knowing Dr. Demetrio for, I don't know how long it's been, a few years now.
Yeah, it's been a few years.
And we share some things in common. Not the medical background. I don't have a medical background, but we share that we are the FMMA leaders. I am for Wisconsin. Demetrio's for Nebraska, and doing a fine job. In fact, I joined him in an event recently, but really, I would call Demetrio, I would call you a friend. We're together in this movement, but I just appreciate everything you're doing, and your story is amazing. And what I'm also finding in these docs that go independent, that have these independent surgery centers, as I travel around the nation, and they're also taking care of patients in a special way and in a better way. So I'm really excited to hear your story. And right, we're not here to impress anyone. We're not here to put on some kind of show. These are just real stories, real doctors, and real people. And just thanks again. So maybe we can start off. Just tell us kind of about where your background and how you got to where you are today.
Sure. So, my background's rather convoluted. I went to med school at Boston University. I was in the combined BA/MD program there. And my senior year in college, I joined the Air Force. And the Air Force agreed to pay my way through medical school. And then I was in the Air Force between active duty and the reserves for about 22 years, almost 22 years. And in that time, I got some amazing training. I started out as a flight surgeon flying fighter jets, F-16s in Korea and then in Japan, and then deployed all over the world. Uncle Sam took me to 46 states and 31 foreign countries. I got all kinds of awesome training along the way. I mean, the Air Force sponsored me to do my ear, nose, and throat surgery training at Mount Sinai. And then later on, I got sponsored to do plastic and reconstructive surgery training at Johns Hopkins and at the University of Maryland. And then I did my peripheral nerve surgery fellowship at the Dellin Institutes for Peripheral Nerve Surgery in Las Vegas. Big roller coaster ride. But my career in medicine actually started when I was 10 years old. I was my dad is a retired physiatrist, and I started working in his office when I was 10, emptying trash cans and scrubbing toilets. And by the time I graduated from high school, I had done every single job there was to do in a physician's office except be the physician. And I think what's most relevant to this story is that when I was 14 years old, I was my dad's billing manager. Okay. Can you imagine today a 14-year-old being a billing manager? or managing, anything other than maybe a burger joint, know. Yeah, and it's not because I'm some kind of rock star, accounting genius. It's because it was actually really simple back then. This is before major medical health insurance really took off. And patients would come in. We had this was all done, on paper. Actually, it was a cardboard ledger card that we had for each patient. And when the patient would come in, I would pull out, I'd go through the files, I'd look, oh, here's the ledger. Okay, patient visit, $20. And I'd write that in. I'd write in patient payment, $20. And then I'd write in balance, 0. And that was it. That was my entire job. And it was pretty simple. I mean, I would imagine working in a grocery store was probably more complicated than what I was doing as a billing manager. And I carried that with me for a long time. And when it was finally time for me to hang up the uniform and go out and be a civilian, I looked really hard at different opportunities. Ultimately landed in Nebraska because some of the nicest people in the world I've ever met are right here in Nebraska, and we never looked back. But one of the things I discovered was that when you sign a contract with a larger employer, whether it's a hospital-based system or whether it's a large private practice, they make you a lot of promises based on assumptions that they've made, based on assumptions you've made. And then you shake hands and you sign on the dotted line and you say, okay, this sounds great. And at first things went pretty well. I mean, I was getting paid pretty well. And they said, we don't care what you do as long as you stay busy. I said, okay. And that went on for about 4 years, but I started to get frustrated when the hospital started telling me, look, you're doing too much of X and not enough of Y. I was like, you told me you didn't care what I did as long as I was busy. And they're like, yeah, well, we didn't know you were going to be busy in this way with this stuff. I mean, I was booking surgery, 6 months out. And so I was like, my schedule is full. And things were going well in that regard. And they said, no. We want you doing this other stuff instead of the stuff you're doing. And that was when I started to get frustrated. And then when I wanted to start making changes to how the practice ran, I really wanted to customize the experience to my patients, really tailor it for them because it's a unique population that I treat. And the hospital really wasn't all that interested in that. And so I turned to a mentor of mine and also a good friend of mine, Keith Verbicki. He's an OBGYN. He's been in practice forever, seemingly. And I said to him, listen, Keith, you've got all this experience running a surgical practice on your own. You've been on your own pretty much your entire career. Can you show me how to do this? He said, sure. He said, this is what I recommend. Go to the FMMA conference. They'll teach you how to run a practice. This was back in 2017, right? And I said, okay. I don't know what this FMMA is, but I'll go check it out. And so I went to the conference thinking, oh, this is a practice management conference, one of those, how to kind of conferences where you learn how to do X, Y, or Z. And I showed up, and my initial experience, and you've heard me say this before, Matt, was holy crap. I hear a whole bunch of people speaking, and they sound like they're speaking English, and it looks like the words they're using are English. I have no idea what any of them are saying. They're talking about stop loss, and they're talking about self-funded versus, or self-insured versus level funded versus, this, that, and the other thing. And I was like, what the heck is all of this? Did I actually come to the right conference? I mean, clearly there's admin stuff that I know nothing about here. But it all came together when I'm pretty sure it was Jay Kempton got up and he started talking about the difference in the cost of care for a total hip replacement, the difference in the cost to an employer. And of course, I'm just starting to get an idea of the fact that employers are paying for this, not the insurance companies. It took me a while afterwards to really wrap my head around this. But, when I started to understand, wait a minute, so employers pay somebody else so that somebody else can then take care of all this, but the employer is the one that's footing the bill. I was like, oh, I didn't know that. And So he started talking about the total cost of care for a total hip replacement at the University of Oklahoma versus the Surgery Center of Oklahoma, where they bypass insurance altogether, as you know, and just set up a direct contract. So same care provided by the same surgeons, because the surgeons have privileges at both places. So, and of course, total cost of care. So from the time the patient identifies that there's a hip problem till the time the patient's discharged from physical therapy, discharged from the surgeon's care, etc. And I was shocked. Shocked. There isn't a word in the English language that I'm aware of to describe how I felt when he put those numbers up. And he said, yeah, $275,000. And I was like, wow, that's a lot of money. I mean, I knew, orthopedic surgery was expensive. I had no idea it was $275,000. It's up comparable numbers for the Surgery Center of Oklahoma, and it was $15,000. I was like, and he put up a comparison side by side. All the these are the same services, and actually you get better outcomes at a surgery center than you do at a hospital. That's well established for a number of different reasons. Literally, I had to stop myself from running out of that ballroom and just vomiting all over the floor. I was physically ill, and I was sitting there just struggling. If you had a camera on me, I'm sure I was turning all kinds of colors, because immediately my thought was, how many of my patients have I done this to? And right away the answer came to me. How about all of them? Every single person I had taken care of since I was a civilian. And in that moment, I started to think about different interactions I'd had with patients over the previous 4 years leading up to that. Thinking about, the different complaints that patients would come in with that at first glance seemed, I was like, well, that's beyond my control. Patients would come in and they would yell at me. Doc, I didn't know it was going to cost this much. I have no idea how much things are going to cost. I didn't know that. If I had known that, maybe we could have had a different discussion. And then I started thinking about the things that we talk about in residency and in medical school. Make sure that when you talk to your patients about the surgery, you tell them about the risks, benefits, and alternatives. Those are the 3 key words. Every surgeon knows those words. Risks, benefits, and alternatives of surgery. I'm like, well, are we talking to them about the financial risks, benefits, and alternatives? I mean, shouldn't that be part of the conversation also? And so all these ideas started spinning in my head, and I got home, and I spent a lot of time praying about this, spent a lot of time talking with my wife about it. And we came to the conclusion, if I have to go back to the old way, and the old way meaning, working within the insurance model, because I realized that was the problem, and I had hurt all these patients. Now you could argue, oh, well, but you didn't know, so you're not morally culpable for that. It's okay. So I'm not morally culpable because I was ignorant, but I'm not ignorant now. And so moving forward, knowing this, I am morally culpable. I someday I have to stand before God, and I have to answer for what I've done. And now that I know, there's no excuse, right? And in that moment, my wife and I were talking and praying about this, and we agreed. If I have to choose between going back to the old way versus flipping burgers in order to stay out of hell, then just hand me the spatula, because at least I know how to use that.
You are listening to Lifeboat for the White Coat podcast.
Yeah. And I mean, incredible story. And it's some of these numbers we throw around, like it sounds like we're making up numbers or something. Tell me if this is your experience, and maybe it's not every case, but I talked with, Keith Smith, Tim Murray in Wisconsin, these guys, these docs.
Sure.
But in the what is today, it's went up a little bit. SCO hardly ever raises their prices, but say what is it, $17,000, $18,000, $19,000 hip replacement today at these independents, these rare independents, the surgeon makes more on that surgery than he or she does on the 200. Is that your experience?
It's totally my experience. I mean, let me give you a concrete example from my experience here, in Nebraska. So, the average cost, and this is not, so let's back up a little bit. So there's the cost like the list price, so to speak, right? The MSRP of the surgery, right? That's not, and you know this, Matt, that's not the cost that the employer pays to the insurance carrier, right? So the cost that the insurance carrier charges the employer for negotiating these prices and everything and doing all the other stuff that goes along with it is far higher than the MSRP because the employer typically never finds out the MSRP, right? So let's just keep that in perspective. So for a unilateral carpal tunnel surgery in the Omaha area, the cost, the list price, if you will, for that under general anesthesia on one hand, with a mini carpal tunnel release in an operating room, and let's say a hospital operating room, somewhere between $15,000 and $20,000. Okay, and for that, the patient has to take a day off of work because of the effects of the general anesthesia. Somebody else has to also take a day off of work to be with that person, and then it's 3 to 6 weeks before that person's back to all their regular activities without restrictions. Compare that to my practice, okay, where I can do both hands under local anesthesia with a little bitty 5mm incision using ultrasound guidance. The patient can drive him or herself home, which is typically what they do. Sometimes they'll bring a family member, but they can do it under local anesthesia in the office. We've had patients, I've had, farmers and ranchers come in on their lunch break to get their carpal tunnel surgery done. Okay. So they don't have to fast and they can go right back to work if they want to in a limited fashion. And those patients are back to work unlimited in 3 to 4 days. And we can do both hands simultaneously for less than 1/4 of what the average is for one hand under general anesthesia here in Omaha.
Yeah.
So yeah, and because this is all under my control, all under one roof in my office, our margin is bigger than it would have been, with all the administrative costs associated with doing it the old-fashioned way.
Have you had conversations with hospital administrators tell me a little bit about when you had this aha moment and you're doing some soul searching. I would imagine you've had more than one conversation too with administrators, or how can we make this better? How do we fix the system? Can you share a little bit about your experience, what those conversations were like? Were you beating your head against the wall, or, is there hope for the hospital systems, or do we just have to find a new way altogether? I guess I'd be curious.
That's a great question. An awesome question. So I'll address that 2 ways. So number one, when I came home from the FMMA conference in 2017, my wife and I were talking, and I spent a bunch of time praying, and I was like, how, because I began to understand that the insurance companies negotiate with the hospitals on behalf of their beneficiaries in order to get discounts off the list price, right? But the people who don't have an insurance company very often, and I saw this myself, were the ones who had to face the entire list price. So in other words, the most vulnerable people were the ones that the hospitals were taking advantage of the most. They didn't have anybody advocating for them. They didn't have anybody offering them options, for discounts and so forth and so on. And they're the ones that got hurt the most. And so again, I spent a bunch of time praying about this, and it came to me, in prayer, what we call the M25 program. It was featured on CNN's Champions for Change. The M25 program was on NBC Nightly News, CBS This Morning, a few other news outlets. And basically, what I wanted to do was say to patients, look, specialty care often subjects people to crushing medical debt. And I said, let's say we can do the surgery for free. Right? There are places that'll do that. They'll do the surgery for free. But what do we know about how much the average American values something they get for nothing? They value it about that much, right? And so the question isn't about money, right? The question is, how do you take somebody who has no money and get him to invest in himself in order to get better outcomes? Because study after study has demonstrated that patients who are invested in their outcomes get better outcomes. And so as a surgeon and as a perfectionist, I want my patients to get perfect outcomes, right? And so I want them to have every tool available to them to get those outcomes. Why would I take away one of the greatest tools for the success by saying, let's do it for free? I mean, orthopedic surgeons make patients go through physical therapy before and after surgery in order to get the best outcomes. I mean, why don't they just say, well, it's such a burden for you to do physical therapy. Let's just remove that burden. Well, because they get crappier outcomes. So it's analogous. So anyway, I took this idea to the CFO at the hospital, and I said, look, what if we had patients volunteer at a local charity, volunteer a bunch of hours, and once they've volunteered enough hours, then they can get the surgery, and we'll waive their surgical fees. I mean, we're supposed to do some degree of charity work anyway. It fits within the tax requirements. And I said, why don't we just do it that way? And the CFO loved the idea. He was like, oh yeah, that checks so many boxes, and it really fits with our mission statement to really do Christ's work and so forth. Let's go talk to the CEO. And so we went. So the two of us went and we talked to the CEO, and the CEO looked at me and he was like, I don't know where you come up with these crazy ideas, and he said, but we got bigger fish to fry than that. And so I looked at him and I said, in so many words, I said, well, if you guys have bigger fish to fry, then I'll just fry the fish myself. And so that's when that was the straw that broke the camel's back. We opened up the practice. We built the entire practice around the M25 program to support the M25 program. And so every person that walks in the door can choose. I can pay cash for my surgery, or I can volunteer my time. Who decides who qualifies for the program? The patient does, right? They decide what's more important to them, my time, my money, or my problem. Nobody has to look at their financial records. Nobody has to look at their, at their taxes or their bank accounts. I mean, I've had a lot of patients come to me and say, Doc, I've tried those so-called free care and charity care programs, and those people are really nice and they're friendly, and they try to do everything in a way that's really above board. But when you start showing them all your financials, it's really embarrassing. You feel like you're standing in a stadium full of people and you're standing there completely naked. And I didn't want to subject my patients to that either. And nobody decides who qualifies for this program other than the patients. And when the CFO was excited about us, oh, maybe we can actually do something with this. And when the CEO said, forget that, then I was like, okay, well, then we're just going to do this on our own.
You are listening to Lifeboat for the White Coat podcast.
Now, in order to answer the rest of your question, do we, is there hope for the hospital systems? I think for some of the larger hospital systems, they're so set in their ways and they're so tied to the status quo that they can only see 12 months ahead of them, and they're like, well, it looks like we're going to do okay for the next 12 months, and we'll just keep doing what we're doing. Why should we change things? Why should we fix something that isn't broken? Well, because you're not the one that's feeling the pain. It's not your problem until it's your problem. But having said that, we've had some success now with some critical access hospitals that are small, they're nimble, and they're open to what I like to call my crazy idea. And I don't know that I'm at liberty yet to discuss the name of the hospital, but we have a critical access hospital right here in Nebraska that we're helping to move into free market medicine. And they're doing it incrementally. I mean, you can't turn a battleship on a dime instantaneously, right? But they're taking steps, very real, concrete steps, to offer direct care in a way that's transparent and affordable, without burning the bridges that they need in the meantime in order to keep the lights on. And so I think there is hope, and I think the hope comes from a decentralization of much of the care that doesn't need to be central. I mean, it really embodies the principle of subsidiarity, where we all know intuitively that the best solution comes from the problem solvers who are right in the trenches closest to the problem. Local problems are best solved by local solutions. Dave Chase talks about that, community-owned health plans. I mean, does it make more sense for the people who are addressing the problem, the ones who are suffering from the problem, or does it make more sense to offload that to somebody in an ivory tower 1,000 miles away who's never actually met you before?
I just want to mention for the people that are listening, Dr. Aguila, he has a website. Well, first of all, if this is the first time that you're hearing about this concept of basically community service for specialty services from a healthcare perspective, go check out his website. It is totalpainsolutions.net, and click on the tab that is called M25. And for you doctors who are out there, independent now or considering going independent on your own, go and check out what he is doing in this space. This is an unbelievable opportunity for you to continue, I'll call it his mission, and bring this to other parts of the United States. So I just wanted to bring that up on where to find that information, because this is amazing.
Yes, thank you for that. And I want to mention two things if I can. Number one, my main purpose in setting up the M25 program, I mean, there's only so many people that I can help personally, right? My primary intent in setting it up was to inspire other doctors to understand and realize that as a group, we are the smartest people in America, okay, collectively. So I refuse to believe that if we put our minds to it and we're truly dedicated, that we can't solve this problem. And the M25 program is a piece of that. And am I saying it's the solution for everybody? No, I'm not. What I'm saying is that this is the solution that works for the community that I serve and the practice that I work in. And so I want to inspire all of you and encourage all of you who are watching this to find solutions that suit your community and suit your practice and the people that you're serving. Can you use the M25 program as a template? Absolutely. And I'd be happy to show you how to do that. But, don't think that, oh, well, only one person can do this. We can all do this if we choose to. And that's the key. We have to choose to. The other thing is, as with any other charity organization and effort, we need help. And we're looking for donations to help support the program. And if I can put in a shameless plug for the M25 program, if you go to that tab about the M25 program, you can donate right there. And obviously, we're happy to get $5,000 donations, but even $5 donations make a big difference. And so I would ask you to prayerfully consider that. And here's the other piece of the puzzle. So one of the things that direct care physicians hear all the time, whether and in my experience, it's almost exclusively from other doctors who are afraid to make the leap. And I've heard it in different ways. I've heard it in ways that are genuinely very interesting. I've heard it in ways that are, a very pointed accusation, and it always comes across in some form as, "Why do you hate poor people so much?" Like, "Oh, well, you're going to make them pay cash instead of using their insurance. Why do you hate poor people so much?" I can reverse the question and say, "Well, you're using insurance and raping them financially. Why do you hate poor people so much?" But instead, I usually say, "Well, look at the M25 program. I don't charge these people a penny. How can you say that I'm greedy if I'm willing to do the surgery without getting any financial, benefit from it?" And the M25 program can only exist because we're a direct care practice. Because what I discovered is that when I tried to implement this within the context of an insurance model, it's a violation of all the contracts. If I say, "Oh, well, you don't have to pay, but so-and-so has to pay money." Well, the insurance company says, "Oh, wait a minute. You can't do that. You're violating your contract. Your contract says that this is what you have to charge, and these are the forms of payment you can accept. Oh, and by the way, if you're a Medicare participant and you do this, not only have you violated your contract, but you've broken the law." And I don't think I look so good in stripes.
Dr. Demetrio, your story is powerful, and I knew this time would fly. I've got a couple more for you here.
Sure.
But your story about, I don't think I had heard that one from you before. Your story about being the billing manager at 14. I mean, we look at what big insurance has done today, and we realize, we look back 40-ish, I would say, give or take 40-ish years, and we see that things weren't so complex. And the question is, do they really need to be, or were they done that way for reasons? So there could be many more hands in the cookie jar, and no one knows who's taking what, who's grabbing the cookies and how many, and it's added so much cost. We know that Preston Alexander has done research. I don't know if you've seen this, but big insurance pulls $100 million per day out of local communities and ships it to shareholders in Wall Street. Now, I'm not against Wall Street. I'm personally a capitalist, but that's wrong. I don't care who you are. That's wrong. But I love your story about just this notion of conscience and being complicit. I've heard Keith Smith say these things. We've heard a lot of docs, right, who are like you. Keith Smith says the oath we took in medical school of do no harm also means that we're supposed to take care of the person financially. Right? What good is it to heal somebody and have them go bankrupt? Things like that. So I like to ask my home run question. I know you got to get to your trap meet with your kids as well, so we'll respect that. But my home run question is, the purpose of the Lifeboat for the White Coat is to support physicians who are either independent or looking for someone through an Indeed type posting website, but also to start a practice. If a doctor is inside and is very frustrated, as many are, having been one of those in so many forms, with a very unique background. But what would you, if those physicians within the hospital systems are listening today, what would you tell them, if just straight up?
Oh, that's a great question, Matt, and thank you for asking that. If we're talking about, mechanically, logistically, how do I get out of this trap? How do I free myself from the golden handcuffs? The very first thing I would recommend is figure out where the closest FMMA chapter is. Okay, because whether you believe it or not, and I wish I had known this when I started out, but there are other people that aren't that far from you that are either already doing this or trying to do this. There are various stages of the transition, and freeing themselves from their Stockholm syndrome, and so first I would encourage all of you out there, go to the FMMA website, fmma.org. Okay, I'm not being paid to say this. Yeah, go to fmma.org and look up your local chapter. Figure out where the nearest chapter is. And if there isn't one, then figure out who can you talk to through the FMMA that'll help you do this. Okay, so you can reach out to Keith Smith directly. You can reach out to me directly. You can reach out to, if you go to the FMMA website and you look up the chapters, you look up the Nebraska chapter, you can reach me through that. The email address is right there. It's nebraska@fmma.org. You can reach out to people like Lynn Ann. There's a whole bunch of people. I imagine, Matt, you can give them some advice too. But reach out to the people that are already doing this in order to get the ball rolling. The next thing to do, and this can be challenging, okay? You want to try to figure out who else do you know that feels the way you do as strongly as you do. Now this can be a little tough to navigate because, as I'm sure some of you can understand, you might feel the pressure from your colleagues to not jump ship, because I think there are a lot of people, the most hostility that I get about this is from other physicians, which I find, at first I found rather surprising. I was like, what do you mean you don't want to do things a better way? But I think intuitively they understand the moral implications of continuing in the system, and the more you bring it up, the more it hurts, and they don't want to have to look at that. And so, you have to step lightly when you're trying to figure out who amongst your colleagues you might at least commiserate with, and maybe even collaborate with, to try to jump out there and do it. I would also encourage you to find resources, concrete resources like Freedom HealthWorks is a great one. Another one, Dr. Dan Paul. He's an orthopedic surgeon in Colorado Springs who set up an online course to teach surgeons and other specialists how to start up and run a direct specialty care practice. Be ready for some really significant paradigm shifts. If you think what you're thinking about now is outside the box, it gets way more outside the box until you finally throw away the box. Dan Paul, he started his practice out of his car as an orthopedic surgeon. He bought a portable x-ray machine and just did house calls, and he posted on his website, which he runs himself, his prices. And actually, I don't think he has it any longer, but originally he had, a bullseye centered around Colorado Springs. And if you were in the center of the bullseye, then your consult cost this much. And if you were in the first ring of the bullseye, then it cost this much. And if you're in the second ring of the bullseye, it costs this much, and so forth. really outside the box thinking. He said, well, do I really need an office? Do I really need all that staff? I mean, up until I think last year, he was the only person that he paid out of his practice. And now his wife works for him part-time. And now 85% of his practice is going to see patients in direct primary care docs' offices because they invite him in. They say, look, use our space. We just want to have somewhere that patients can see can see a specialist like you. And so he's pretty busy with that. But one of the great things, and here's another bit of encouragement I would offer to those that are thinking about this. Matt mentioned that that I'm at the state trap shooting competition. You can see that right there. Okay, my oldest daughter is participating in the Nebraska state trap shooting competition. If I were in an employed model, I wouldn't have the flexibility to do these kinds of things. I didn't have that kind of flexibility before. I have all kinds of flexibility because my overhead is really low, and I can run my practice the way I want to run my practice in the way that serves my family and my patients the best. So it can be very daunting. It's I'm not going to tell you that this is really easy and you just turn off the lights at one place one day and you turn on the lights at another place another day and that's it. It's not that simple. But when the most important things are often the most challenging. And all of us that have been through medical school know medical school was way harder than anything we had done before that. Residency was even more so. This isn't any different. When I applied to medical school, 2/3 of the people that applied didn't get in. That means there was a 2/3 chance, a 67% chance of failure, right? When I applied to residency, there were 2,000 applicants for 2 spots. Okay. That's a less than 1% chance of success. And I did it anyway, right? Why? Because I really believed in myself and I believed in what we were doing. The risk of failure in going into direct care is far lower than either of those two things. You just have to choose. You have to decide that it's important enough and then put on your big boy pants and do it.
I always, I love this phrase. If you want to be successful, model somebody who is successful. So I know that you've offered yourself for folks to reach out to you. And I thank you so much for that. And all of the other doctors that we have interviewed as well have said the same thing. So there is a very unique community here that everybody just wants to help everyone because there does need to be a faster paradigm shift in the United States for this healthcare hellhole that we are in. So I truly appreciate you offering that. Any last words from anyone?
Yeah, I'll just say, Dr. Demetrio, thank you for your time. It's certainly very meaningful for me that you took the time to talk to us, and just your story is inspiring, and more power to you, my friend. If I can help you in any way, let me know. But you are doing great things, and so many across the country are doing great things. It just takes a little courage. And I'll say this as well, right? If I were the big health systems, what we call the healthcare industrial complex, and I wanted to control somebody, I wanted to mess with somebody, oppress somebody, or put them in golden handcuffs, the MDs would be the last group I would do it, because you're talking about the brightest, the most resourceful, the most motivated. And so if you're a physician out there and you have doubt, there are resources to help you. Let's go. I know you're capable.
We have a website called whitecoatlifeboat.com that is a job board. If you are looking to go independent, our current independent practices that have positions listed. Also, if you are an independent practice and looking for additional folks who have the right hat on to work at an independent location, feel free to go and apply and put your resume out there as well. So thank you so much, everybody, for taking the time out this morning. We wish your daughter the best in her competition today. And
Thank you.
I have so many more questions for you. Hopefully we can do a second round with you a couple months down the road, because I like to dig down a little bit deeper.
I would love to do that. And then, that we won't have to contend with the state trap competition, so we can do it from my computer at the office or my computer at home and give you an even better experience.
This concludes this episode of Lifeboat for the White Coat podcast. Please make sure you visit whitecoatlifeboat.com.